visual signs of trauma.
Hi, I'm Dr. Ted Delbridge, Executive Director of the Maryland Institute for Emergency Medical Services Systems. One pillar to providing high-quality emergency medical services is the ability of our clinicians in the field to receive appropriate guidance from a hospital base station. Your service, the job you do, is pivotal to providing high-quality emergency medical services throughout the state of Maryland. We also know that time is one commodity you just can't get back. Therefore, we're appreciative that you're spending just a bit of yours to receive this protocol update for 2019. Thank you very much.
Hello, my name is Dr. Timothy Chesmar, and I am proud to serve as the new State EMS Medical Director at the Maryland Institute for Emergency Medical Services Systems, or MIMS. Through our protocol development process, we strive to equip our EMS clinicians with the most up-to-date and evidence-based guidelines for the treatment of our patients in the field. My goal with this presentation is to provide you with a succinct review of the 2019 updates to the Maryland Medical Protocols for EMS providers. We've made several revisions to streamline the adult tachycardia algorithm this year. Hemodynamic instability will be the initial decision point for our EMS clinicians. Synchronized cardioversion will be indicated for the unstable patient, while monitoring or medication will be indicated for the stable patient. Also, adenosine has been removed for treatment of regular monomorphic wide QRS complex tachycardia. We have added a treatment pathway for irregular polymorphic wide QRS complex tachycardia, such as Torsade, incorporating the use of magnesium. For patients with an accessory pathway, such as those with Wolff-Parkinson-White syndrome, the protocol will direct the EMS clinician to perform cardioversion for hemodynamically unstable patients. However, if the patient is stable, the protocol will direct the EMS clinician to monitor and transport without medication. For diltiazem, the consultation requirement has been removed for 2019. ALS clinicians may administer diltiazem for atrial fibrillation with rapid ventricular response if the systolic blood pressure is greater than 100 millimeters of mercury. Fentanyl will now be the standard or required opioid analgesic for the treatment of moderate to severe pain. Initial dosing will be 1 microgram per kilogram, not to exceed 200 micrograms if the patient is greater than 200 kilograms. EMS clinicians may repeat a dose of fentanyl at 1 microgram per kilogram in 5 to 10 minutes if the patient still has moderate to severe pain. Medical consultation is required beyond the second dose. The preferred route for fentanyl administration will be intranasal, keeping in mind that there is a maximum of 1 ml per nair. This route will minimize delays associated with obtaining intravenous access. Morphine will now become an optional medication for EMS. Epinephrine has been removed from the adult traumatic cardiac arrest treatment algorithm this year. It has been shown that epinephrine is not beneficial to the adult patient in traumatic cardiac arrest. Additionally, epinephrine may cause delays in addressing reversible causes on scene, such as tension pneumothorax and transport of the patient. We've made some modifications to the needle decompression thoracostomy protocol this year. The indications will remain the same, including life-threatening pneumothorax with a patient who is in extremis with absent lung sounds and hemodynamic compromise as evidenced by hypotension, or for patients in traumatic cardiac arrest due to multi-system blunt trauma or penetrating trauma that may have reasonably caused a tension pneumothorax. The primary recommended site for our EMS clinicians will be the 5th intercostal space at the anterior axillary line. The use of a flutter valve will be optional and medical consultation will not be required. Of importance, the catheter should not be removed once placed. The 2nd intercostal space at the midclavicular line on the anterior chest wall will remain in the protocol as a secondary site if the primary site is not available. The catheter should not be removed once placed. We continue to focus our efforts on improving survival from cardiac arrest. To that end, for pediatric high-performance CPR, a clarification has been added to the protocol this year, which specifies delivery of breaths just after the 14th and 15th compressions for 2 rescuer CPR. This will minimize interruptions in compressions. As a reminder, for single rescuer pediatric CPR, the ratio of compressions to breaths is 30:2. For 2 rescuer pediatric CPR, the ratio of compressions to breaths is 15:2. We will have a goal to achieve a compression fraction greater than 80%. What this means is that compression should be occurring at least 80% of the time during the resuscitation attempt. Based on recent literature, the time window for transport to a primary or comprehensive stroke center has been extended from 3.5 hours to 20 hours since the patient was last seen normal. In addition to performing a Cincinnati stroke scale, we have added the cerebellar assessment for EMS clinicians. We will ask the EMS clinician to consider a sudden loss of balance or dizziness, or a sudden loss of vision as a potential indicator of acute stroke. We will also ask EMS clinicians to check a glucose early on in their assessment. Importantly, EMS is required to document a contact person and phone number so that hospital staff may obtain further history about the patient. For patients without a MOLST form or valid DNR order, a physician assistant may now verbally authorize a DNR order if they are physically present on site. This is in addition to physicians or nurse practitioners who are present on site. EMS clinicians should document the name of the on-scene physician, nurse practitioner, or physician assistant who authorizes the DNR order verbally. For most DNR-B patients, capnography, pulse oximetry, and the use of McGill forceps, as well as ketamine for pain management, are all permitted. Importantly, a patient who is fully oriented with medical capacity may verbally revoke a valid MOLST DNR order. If revoked, the patient may receive treatment from the full scope of EMS protocols. On behalf of our EMS clinicians, thank you for taking your time to complete this EMS protocol update. I want to thank you as well for your dedication to the MarylandEMS system and our patients.